Nearing the end of this unprecedented year and going into the holiday season and a new year, we thought it was timely to give mind to the impact of this pandemic that we're living through and provide our community with insights from someone who's right on the front lines. And I'm happy to introduce him to you now. A veteran ER physician and one of Canada's most trusted medical broadcasters, Dr. Brian Goldman is playing an important role in educating, addressing concerns, and dispelling misinformation during the COVID-19 pandemic. He's a highly regarded ER doctor at Toronto's Mount Sinai Hospital. You may know him as host of CBC's award-winning radio show, White Coat, Black Art, and the popular podcast, The Dose, where he demystifies what's going on behind medicine's sliding doors, including whistleblowing, burnout, racism, and sometimes how to get to the head of the line in healthcare. He's the author of 4 books, including the best-selling The Night Shift, Real Life in the ER, The Secret Language of Doctors, and 2 on kindness, including The Power of Kindness. Recently featured in a special edition of Time magazine, where he explores why empathy is essential in everyday life, which is something we could certainly all use more of this year. Welcome, Dr. Goldman. We're so fortunate to have you with us today, and I'm happy to turn it over to you.
Thank you so much, Teresa. And I have to say that you and everybody at NSB have empathy in spades. So thank you for inviting me, and it's a pleasure to speak with you. I guess, it's bittersweet because I would love to be able to speak to you in person. But through the magic of Zoom and virtual meetings, we have an opportunity to meet from all over the world. I know there's people from all over North America who have tuned in. And in the next 10 minutes, I'm going to give you a little status update on COVID-19. I'll talk a little bit about, I'm going to talk mostly about Canada. I'm not going to try to kind of snow you with lots of figures, just some of the key ones. Where we are, why we are where we are at this point in Canada, a little bit about the United States, and what does it mean that we have, that we're dealing with this pandemic? How has it changed things? How is it changing healthcare? And how is it changing us? And of course, you all, I'm sure, want to know a little bit more about the vaccines that are out there, and I'll talk about them because there is some news from Canada. Health Canada became, I guess, the first country in the world to conduct a full independent analysis review of the Pfizer vaccine and has granted approval. And so that means within a matter of hours, subject to the logistical issues, which I'm going to go into, Canadians will be receiving the vaccine. Of course, in the UK, they've been doling out the vaccine for the last couple of days, but they conducted what's called an emergency review and not a full independent review. They used the data that was supplied by Pfizer. And so it's a little bit different in Canada. And, if you've got questions about that, I'll be happy to answer them. So let's start with the status update of COVID-19. I would characterize the situation in Canada right now as we are knee deep, or perhaps we are armpit deep in the second wave of COVID-19, with about 6,500 new cases per day. Overall, we've had just under 500,000 cases. The vast majority have recovered. Unfortunately, there have been close to 13,000 deaths. The United States has seen 15.2 million cases, and you can watch the ticker on CNN. It's going up and up and up. They're having anywhere from 120,000 to 200,000 cases per day, and probably as they make their way through the bulge brought on by the Thanksgiving holiday, when people got together when they weren't supposed to, we're going to see higher numbers, and we're going to see, unfortunately, more deaths. Right now, there are 286 deaths, and there are concerns that somewhere around February they could be looking at 400,000 or more deaths, which is really unprecedented, except for the last global pandemic, serious global pandemic, which was the influenza pandemic of 1918 to 1921. The Canadian death rate right now from COVID-19 is better than the United States. It's about 30 to 40% the death rate of the United States, but it's no record to be proud of. We know that we've had a disproportionate number of deaths in Canada in people who live in long-term care facilities. And you know, there are many reasons for that. We allowed outbreaks to occur. There, we've started to get some industry reviews and some independent reviews in some provinces. And some of the factors that led to this disproportionate infection rate in long-term care facilities had to do with low pay for personal support workers, personal care aides, forcing them to work in multiple sites, increasing the risk of bringing the infection from place to place to place. Lack of PPE. This was a major problem, and it caused high rates of infection among healthcare professionals who work in long-term care. There was a lot of burnout, a lot of exhaustion, and because frail seniors, particularly those with dementia and other comorbidities like chronic congestive heart failure and chronic obstructive pulmonary disease, they would be more prone to getting COVID and dying of COVID. We had a disproportionate set of outbreaks in long-term care facilities, and it's really a national shame. And it's something that leaders in geriatrics like Dr. Nathan Stahl, Dr. Samir Sinha have called a national shame, and I would certainly agree with that. Another factor is the infrastructure in long-term care facilities, where we still have a significant number of long-term care facilities that have 3 or 4 residents living in a single room, which with shared bathrooms, which is a recipe for sharing the infection around. Here in Ontario, we're having about 1,800 cases per day. And you know, I know a lot about Ontario because I live here. I know that a few weeks back, as we entered the second wave in this particular province, there was a cutoff point, kind of a threshold level of admissions to the intensive care unit of 150 admissions that might trigger the consideration of postponing scheduled surgical procedures and MRIs. That really didn't happen. One of the differences between the second wave and the first wave is that the first wave really caught the hospitals rather unprepared, and they had to make preparations. Now, during the second wave, they certainly seem to have a better ability to increase their capacity of ICU beds, to repurpose wards in a hurry and make them COVID-only wards. And so there's a lot more of a shock absorber in the system, at least in this province. That's Ontario. But I have to tell you that in other parts of Canada, Alberta in particular, I know we have some people from Alberta who've tuned in. Alberta is in a really bad stage right now. Ontario is having 1,900 to 2,000 cases per day. Alberta, with a much smaller population, has 1,800 cases per day. And so they're in far worse shape. And we are starting to see, you know, lockdowns, which have been announced in Alberta. We have lockdowns in several jurisdictions in Ontario. And what that means is that first of all, there's no in-store shopping, except there are exceptions. There are stores that are allowed to remain open because they sell essential goods like grocery stores. But most of the other shopping is curbside pickup only. Bars have been closed. Restaurants have been closed to sit-down dining, takeout only. Gymnasia have been closed. You know, fitness centers have been closed. Hair salons, massage salons, and the like have also been closed. One of the things that we've talked about on my radio show, White Coat Black Art, is what makes a hotspot. And you know, there's a lot of focus on people doing what they're not supposed to do. So for instance, people attending mass gatherings, people going to weddings, people going to funerals, having larger gatherings at home. And yes, that is occurring. But one of the things we have to realize is that the vast majority of people who are getting COVID-19 are not getting it because they're misbehaving. So the shaming, the naming, the blaming, and the shaming of people is a red herring. And yeah, it does happen, but it doesn't really explain across the population what's really happening. We did a show on White Coat Black Art, and if you're interested in logging on, it's at cbc.ca/whitecoat. We did a really good show, an in-depth look at Brampton, Ontario. It's the 4th largest city in the province, population 600,000. And at one point in the last couple of weeks, there were parts of Brampton that had an infection rate, a test positive rate of 20%, which means that if they did COVID swabs on 100 people, 20 of them would be positive, which is a horrendous number. Right now across Canada, it's 8%, so 8 out of every 100. And so they have high rates of COVID-19. Well, why do they have high rates of COVID-19? They have a large South Asian population, but it's not because of Diwali. It's not because they've been going to weddings and funerals. In fact, I toured a Sikh temple that was empty because people are doing what they're supposed to be doing. They're staying away from mass gatherings. So why are they getting COVID-19? They're getting COVID-19 because they have low socioeconomic status. So they have low income. Low income means that they have to keep working. They can't afford a car, which means they have to take public transit. So they risk getting COVID on the transit routes. They tend to work at jobs that we love that they work in those jobs. So for instance, they work at places like Amazon and Wayfair. We love those commercials. We at Wayfair, you have just what I need. Well, as they said on the show, it isn't little elves that put together those packages for you. It's people who work in very close quarters and risk getting COVID-19. And that's where a lot of the COVID-19 is spreading right now, in manufacturing plants, in factories, migrant farm workers, seasonal farm workers. We've done shows about all of them. These people tend to live in large households, so they can't help it. They're multi-generational, which means they're sharing germs with one another. And so we really have to cut them a lot of slack. And it turns out that in Brampton, there is a huge disparity in access to healthcare. First of all, there is a lack of access to healthcare in the languages that are preferred, so Punjabi, Hindi, and there's lack of foods. Meals on Wheels tend to have vanilla meals that are of no interest to people who have a high spice diet, who have traditional Punjabi foods, for instance, traditional South Asian cuisine. And there are social service groups, community service groups that are charitable organizations, nonprofits, that are trying to pick up the slack there. In addition to that, there is a disparity in access to health care, and I happen to know about this in Ontario because we did a show about it. Per capita in Brampton, they spend $900 per year per person on healthcare services. So everything from MRIs to hip replacement surgery, to cancer screening, to diabetes screening, diabetes management. The provincial average is $2,000 per person per month, and they're spending $900 per person per month in this jurisdiction. And those are the kinds of disparities that you see, not just in Ontario, in Brampton, but you're also seeing them all over North America. And I know this is a major part of the reason why people have such high rates of COVID-19 in the United States. Part of it is anti-mask protests and not wearing masks, but a major part of it are these income disparities and these opportunity disparities that must be addressed if you really want to work your way through the system and relieve the burden of COVID-19. That's all I want to say about risk factors. How has COVID-19 changed us and changed healthcare? It has affected healthcare in ways that are subtle and in ways that are profound. In terms of healthcare, the pandemic has resulted in this country in at least 250,000 CT scans and 250,000 MRIs that have been postponed. And these are not frivolous tests. These are people who need to have staging to see whether they've got stage 1, 2, or 3 cancer. And in addition, there has been a marked reduction in the number of hip and knee replacement operations that have been done, cataract surgery that's been done, and the Canadian Medical Association has estimated that it will cost billions of dollars to pick up the slack and make up the difference, and it won't happen in the next 2 months. Even if everybody had a vaccine today, it would take at least a year to work that through the system. I've already talked about the socioeconomic determinants of health. The pandemic has certainly triggered greater awareness of these disparities that are the major reason why more people are getting COVID-19. Arguably, I would say the greatest impact of COVID-19, unless you have the misfortune of having COVID-19, and that still it means roughly 10% of the population, maybe 9% of the population. That means 90% or 91% of us have not had COVID-19. You may know somebody who was infected. And yes, the people who are infected, the vast majority get better. Unfortunately, people who are older or who are ill, frail, have what we call medical comorbidities are going to be more likely to end up being admitted to hospital and unfortunately dying. And it's a tragedy when that occurs. But I would say that for the vast majority of us, we may know somebody with COVID-19, but we don't have it yet, and hopefully we'll get a vaccine before we get COVID. And I would say the major impact across the population of COVID-19, not including the people who've been directly affected by the virus, are the mental health aspects. And there's no question that we are seeing much higher rates of depression, much higher rates of anxiety, much higher rates of insomnia. The rate of insomnia, that means 3 bad nights sleep, three times a week you have difficulty falling asleep for at least 3 months, or difficulty staying asleep at least 3 nights a week for 3 months. Ordinarily, the prevalence of insomnia across the population is 13%. Right now, it's 21%. So that's a huge difference. We have much higher rates of substance use, particularly alcohol. And alcohol has become a favorite friend of a lot of people, and with all the comorbidities that are associated with that. And opioids, of course, opioids have been a major problem, opioid overdoses. We are seeing much higher rates of overdoses and overdose deaths, in large part because people are afraid to take opioids with others because they don't want to get COVID. So they end up taking opioids by themselves. And so there's nobody with them to give them naloxone to get them breathing again to save their lives. I promised I was going to talk about vaccines. I guess that's the last thing I want to talk about right now. There are over 200 vaccines that are in development. Something like 14 vaccines are undergoing clinical trials, and 7 of them are at the stage of phase 3 trials. We know that we have 4 vaccines that are very close to approval, and they are vaccines by Pfizer, which will be first out of the gate, and a vaccine by Moderna. We also have a vaccine by Janssen and a vaccine by AstraZeneca and that Oxford University. 3 of those vaccines, with the exception of the one by Janssen, are 2 injection vaccines. So you get the first injection today. If you get it today, you need the next one in 3 weeks to a month. Of those 4 vaccines right now, I can say that Health Canada just approved the Pfizer vaccine today in the last hour. And right now, 250,000 doses of the vaccine are going to be doled out. And if you look today in the Globe and Mail, you can see something like, 1,900 doses, per Atlantic provinces. I think Ontario will get a little bit more. The big issue, and we expect that the vaccine will get approval by the Food and Drug Administration in a matter of, it might be today, it might be tomorrow. So that will be the first vaccine that will be available in the United States. It is 95% effective. And the good news is that even after 1 injection, you need 2, but even after 1 injection, you'll probably get some protection. It takes about 10 days for you to start to be protected. So if you get infected with COVID-19 the day after you got the shot, you might not be protected. The good news about all of these vaccines that we've been hearing good news about, all of them have efficacy rates that appear to be in the low to mid 90s. They do 2 things. They reduce your chances of getting COVID-19. They also reduce your chances of dying of COVID-19 in the phase 3 trials that have been done thus far where we have data. We have seen that if you look at who ended up being admitted to hospital, which is a marker for serious disease, or ended up in the ICU, only the people who received the salt water, the placebo injection, had a bad case of COVID-19. All the people who received the actual vaccine had a mild case if they had it at all. What we don't know from any of these phase 3 trials where we've seen the data is the extent to which getting COVID, the COVID vaccine, keeps you from spreading it to other people. So that, that's because these phase 3 trials weren't designed to look at that question. But as we answer that question, as we get more data, I think they'll be able to answer that question for us. It's still valuable for everybody to get vaccinated. You have heard about something called herd immunity, and this really became an important issue in Sweden when Sweden, it's been called the Swedish model, where relatively speaking, they made a decision early on during the first wave that they wanted, they thought that if as many people became infected with COVID-19 as possible, that the infection would in effect pass through the population. And so what they did was they kept the schools open, they kept the businesses open, they kept restaurants open, and they had, of course, higher rates of infection. The Swedish model has now been discredited for a couple of reasons. First of all, it didn't help the economy. It didn't keep the economy going to the extent to which they thought it would. And the other sad thing is that the death rate in Sweden per capita is much higher than surrounding countries with similar sized populations like Denmark and Finland. And they have recently in Sweden abandoned the Swedish model. So does that mean we abandon the concept of herd immunity? No. And I want to conclude on this point. Now that we have at least 3 vaccines with 90 to 95% efficacy, and there are other vaccines. The Chinese vaccine might be 86% effective. The Russian vaccine may be effective. What we don't know, they're not peer-reviewed data. We don't know. We have to be able to follow their data to know for sure whether they're as efficacious. But when you have a 95% effective vaccine, you have a realistic possibility of achieving herd immunity. And herd immunity means that when roughly 70% of the population has been vaccinated, that means that 70% of the population can't propagate the infection, can't get it, and then give it to other people. And if they can't do that, that means that if one person arrives from another country with COVID-19, they're going to be far less likely to start up an outbreak, a local outbreak, which is how it happened here, how it happened in Seattle originally, New York City, Toronto, Vancouver, and elsewhere. And so we are ending 2020, which is annus horribilis. It's been a horrible year, but we're ending it on great news that if we can stick it out for the next 6 months to 8 months, I think we're going to reach a point at which people are going to have a life that is not absolutely normal, but is a lot closer to normal than it was, say, that it is right now. Where I think we'll be able to gather in larger numbers. I think we'll be able to go to sporting events eventually in a graded fashion. We're not going to go from nobody in the stands to 100,000 people in the stands. We're going to do it in a graded way and see what happens. But I think this is our best chance, and it's really great news, and it's quite astonishing, quite an amazing scientific achievement. These are vaccines that didn't exist. And 11 months after the genome for COVID-19 was first sequenced, we now have 4 vaccines that are close to being approved. And just to give you an idea, the second fastest vaccine developed in the history of mankind was 4 years, and that was measles. So congratulations, science. And so what do we do from now until the end? The things that Anthony Fauci has said, that others have said, that Theresa Tam from the Public Health Agency of Canada have said are the things we need to do. Wear a mask. It reduces your risk of getting infected and giving it to other people. Practice physical distancing. Stay at least 6 feet apart from people. Keep your windows open. Turn as many of your activities outdoors instead of indoors, because we know that air filtration and air circulation, ventilation are important determinants of how likely you are to get infected. And you're more likely to be infected by remaining indoors with other people who are infected. And if you're outside, you're less likely to get the infection. So practice physical distancing, wear a mask, stay in small groups, stay in your own bubble, and try to keep the faith, because I think there's good news on the horizon. And that's all I want to say. I think I took a little bit more than 10 minutes, but I'm going to open it up now for questions. And if you got them, I'll be happy to answer them.
Thank you so much, Brian. That was quite a whirlwind of insight that combines the science and the facts that people are looking for with some of the hope in terms of what you see on the horizon, and especially if we all do our part. So thank you so much. We do have quite a few questions that are coming in, so we're going to get to as many of them as we can. A lot have come in through the Q&A function, so I'll moderate those with you. Again, if there's anyone who would like to ask their question live of Dr. Goldman, just raise your hand or mention that in the Q&A, and Lynn, our producer, will bring you behind the scenes to ask your question and then return you to the webinar itself. So with that, I can see a pattern of questions that that combine the kinds of things that we can do for ourselves to protect ourselves, as well as the kinds of things that we can do to protect others. And one of the questions from Peter is about how effective are the lockdowns if people are still allowed to travel between regions?
Yeah, so that's a great question. Lockdowns are effective when they are lockdowns. And if you want to see a model of how to run a lockdown, take a look at Melbourne, Australia, in the province of Victoria. They had numbers that in September that Ontario, for instance, had, and the reason I'm mentioning that is that a lot of people compare Toronto to Melbourne. They had numbers in Ontario that were close to what Melbourne had. Back in August, we had started to get those numbers in Ontario. What they did in Melbourne was an actual lockdown where they shut down all businesses except essential ones. They minimized the number of exceptions. They didn't allow people to gather in places of worship. They had a mass advertising campaign. They actually had a curfew. And if they found you on the streets at night, they didn't necessarily lock you up, but people got the message very quickly to go home and stay home. They were able to zero their rates of new COVID infections. And had we done that in Ontario, for instance, and elsewhere, we'd reach that sunny face. We have never instituted a lockdown with the intention of flattening it to zero cases. And that in part is because, I think Australia has a different mentality. They're an island. They've always been more conscious of a pathogen arriving on their shores and causing devastation. And if you go to Australia, they care a lot about whether you're bringing plants with you or bringing a pet with you from elsewhere. They have that mentality. We don't have that mentality. And one of the reasons why we don't in Ontario and other parts of Canada is that we border the United States and we feel utterly dependent on the United States for the health of our economy. And we're not going to make that. We're not going to do that. And so by definition, we have a much more porous lockdown than other jurisdictions. And as a result, we are going to be paying the price for that. We're never going to flatten it in the same way as they did in Australia. And so to answer directly your question, if you have a lockdown where people are going from place to place to place without quarantining, without self-quarantining, that's a recipe for spreading the infection.
Thank you for clarifying that. Much appreciated. I'm going to combine a couple of questions, including one led by Catherine, which relates to the vaccine itself. Based on what you know, there are questions around should everyone get the vaccine, especially if you feel you've already had COVID, or if there's a sense that you can get COVID twice, will a vaccine really help?
Yeah. So first of all, you should get the vaccine, even if you've had COVID, even if you had antibodies before, because we're going to be mass vaccinating. We are not going to be testing people for antibodies to see if they're already infected. In part because there are ongoing concerns that COVID-19 mutates, and if it mutates, it just like the flu, it may eventually reach the point where the COVID that you got 6 months ago, or 3 months ago, or 9 months ago, is not similar enough to the new strains that are prevailing for COVID-19 that you might that you're likely to get reinfected. Up until now, reinfection rates have been relatively low. but we know that there are anecdotal cases in which that occurs. So the general rule is that you should get the COVID-19 vaccine regardless of whether you've been infected with COVID and have a bona fide, you tested positive before or were found to have antibodies before.
Thank you. Considering the time of year, Lorianne is asking about the education sector. And what do you think will happen there, especially after the holiday break with staff and students that have health conditions in the buildings? Any comments there? That would help?
Sure. I was certainly somebody who advocated for something closer to a lockdown 2 or 3 weeks ago in the province of Ontario, and to do that, it's interesting. It's a bit of a complicated situation when it comes to schools because, there are questions about how important the person-to-person spread, how much spread inside schools contributes to community spread of COVID-19. And there certainly the data from Australia suggested that the spread that occurs in schools, the transmissibility of COVID-19 in schools was not as important as we thought it was going to be. It wasn't as important a contributor to COVID-19 infection rates in the community as, say, person-to-person spread at worker plants, at factories, farms, and other places where people are forced to work side by side, much closer to each other in an indoor facility. Now, so what does that mean? I can tell you that certainly the decision, I cannot say that the decision to close down schools is entirely a scientific decision. I hope we lead with science, but I think it's often a political decision. And it's going to be made by a government that is weighing the impact on the economy and also weighing the impact on parents. Because when kids are not in school, okay, they can learn virtually, and we know there's a lot of challenges with that, but also they need their parents' attention more often, and it gets harder for parents to work from home. So that's one of the major reasons. We also know that for the mental health of kids, they need to be in school as much as possible. So I don't think schools are going to be closed completely, although we might, certainly what I would look for right now would be an extended winter break in association with the holiday season, so that instead of it being 2 weeks as it usually is, or 10 days, 12 days to 2 weeks, I suspect it'll be more like 4 weeks, maybe even 5 weeks, depending on the province.
Thank you. And I know for some parents that's great news, and for others that might be, okay, we'll figure out home life with kids. We have a couple of questions related to mask wearing, and you've made clear the benefit of wearing a mask, but there's some specifics. A refresher for us all would be helpful about how do you properly wear a mask, blue side out, white side out, and are there some that are more effective than others?
Okay, so I got to see, you know what? Do I have a mask here? Just a sec. I'm not abandoning you, I promise.
That's all right. Thank you.
Oh, yeah, I do. I got my bag here. Just a sec. I got it. This is show and tell. Okay.
We like it.
Of course. Okay, here we go. All right. So here is a surgical mask. And okie dokie. So you wear the white side in, the blue side out. And I hope everybody can still hear me. Make sure that you press down hard the malleable bit of metal that's stitched inside. And make sure that it covers your nose and it covers your mouth. And I know you're going to, now I can tell you the more that your lenses fog up, especially, when you're outside in the cold, the more that the air is leaking, and you don't want the air to be leaking. And basically what you should do is just breathe in and out a few times. You want to make sure that you're not leaking too much air on the outside, but it's really important to wear it over your nose and mouth, because COVID can enter your nasal passages. It can infect you through the nasal passages or through the mouth, the oral passages. If you see somebody who's wearing their mask like this, because people often do this, to be social, then gently tell them that they're not wearing their mask right. I'm sure they'll appreciate it, even if they don't know. Now, so I use these. I prefer these. And when I work at Mount Sinai, we're issued 3 masks, which is what for every shift, 3 masks for every day. Basically, I'm going to use it until it's soiled, or I'm going to use it until I take it off to have a meal, and then I'm going to throw it out and use my next mask. We do not, in hospital, we do not use the washable masks because we're concerned about biological contamination. Follow the, but if you are using reusable masks, cloth masks, just keep in mind that while they can help protect you from the virus, the more you use them without washing them, the more you will have bacterial contamination of the mask, and so you could get a bacterial infection instead.
Thank you for that demonstration. That's part of the interactive element of the program. Much appreciated in hearing it from you. There are a couple of other questions about some of the kind of specific day-to-day things that we could be doing. So Dawn is asking about vitamins or supplements, especially vitamin D, C, magnesium, anything that you would recommend to help?
Yeah, we're looking for evidence. There's lots of stuff out there on the internet. There is not a lot of information on nutritional supplements. My usual approach to nutrition is to eat a balanced diet, and that you'll get most of the nutrients you need through a balanced diet. Certainly you should eat properly. You should eat a range of foods that are recommended by the Government of Canada, Canada's Food Guide, the Nutritional Food Guides of the United States, the UK, etc. And make sure you get plenty of exercise. Try to get as much sleep as you can. Keep your alcohol consumption down to moderate levels. I cannot say that nutritional supplements are going to be particularly effective at preventing COVID-19. The most important things you can do are wash your hands, wear a mask, wash your hands frequently, make sure you wipe down countertops and other surfaces that have been touched frequently by other people, and restrict your contact with other people. Certainly, the kinds of things that you can do in homes, you can consider purchasing an air filtration system that circulates air, that filters out the virus particles, and certainly businesses, larger businesses, factories, and sports teams are doing that as we speak.
Thank you for that. And you preemptively answered a few of the additional questions about other things we could be doing around our household. So thank you for that. And so I'll jump to Alana's question, who mentioned that you were a keynote speaker at their national conference in Quebec City, which they loved having you there with over hundreds of people. And just questioning, when do you think it'll be a time when we can bring hundreds of people together again for events, conferences, in-person events?
Yeah, that's a great question, and I have to say that my suspicion is that you were talking about an organization, CNAR, the Organization of Medical Regulators, I think, and the National Association of Professional Regulators of Professional Associations. I suspect that they will operate at the highest possible standards of infection control, and they're going to be conservative, and they're going to wait until long after sports teams have started to have people in the stands. My best hope, right now, Canada is going to receive. Canada has like, really, the answer to your question is how soon everybody can be vaccinated. How soon can we reach 70% of the population vaccinated? I don't see that happening for the first 6 months, and it may be 9 months. So maybe fall of 2021 will be the first time. Maybe it won't be until winter of 2022. But really, the factor that will allow that to occur will be having the population vaccinated, so that we have 70% herd immunity. If we've got that, then I think that we're going to be much better positioned to open things up to mass, to academic meetings and to mass gatherings.
Thank you for clarifying that. And that leads to another question by Michael about efficacy and effectiveness, and as it relates to vaccines. Can you comment on that? And are we going to be disappointed in the reality of how effective things are?
Right now, we are pleasantly surprised. I have to say, we are pleasantly surprised by what we know about the efficacy of the mRNA vaccines. These are messenger RNA vaccines. Basically what they are packets of messenger RNA, which basically are a program, like a blueprint for a protein. So they're injected into your body, they enter the cells in your body, they commandeer the machinery of the body to make proteins, that they're spike proteins that are then recognized by your immune system as foreign. They make antibodies to them. And when you have antibodies against spike proteins are sitting on the surface of the COVID-19 virus particle. When you are infected with the virus, your immune system recognizes those spike proteins and joins them and takes them out of your system. And so you don't get infected with COVID-19, because these have done a great job of filtering out the COVID-19 from your immune system has filtered out the COVID-19 from your bloodstream, from your immune system. So basically, these vaccines, the hope by infectious disease experts and public health specialists was that if the vaccines were more than 50% effective, that we would have a viable preventive treatment. These vaccines are 90 to 95% effective, which is very pleasant surprise. And so that, certainly increases our hope of being able to achieve herd immunity. Now, there are logistical issues. The first one is that we think that people are going to need 2 shots of the vaccine. So if you get the first shot but don't get the second shot, it's not going to be as efficacious, and maybe we won't get as good herd immunity. There are also some issues with the Pfizer vaccine. It's got to be super cool to minus 80 degrees Celsius, and it has to remain in the frozen state. And just get rid of that. There we go. It can be stored in dry ice for a period of time, but this limits the ability of the system to logistically distribute the vaccine to everybody. And then we come to the issue of, what if we have a significant chunk of the population that doesn't want to be vaccinated, that has vaccine hesitancy, that's either afraid of the vaccine or afraid of the speed with which it was developed. And these are issues that are all going to play into the overall effectiveness of the vaccine. So Michael, there are 2 answers to your question. Personal efficacy, 95%. That means once you get the 2 shots, if you're exposed to people with COVID-19, you're good to go. Population immunity, that depends on your neighbors, your friends, your neighbors, your relatives, all lining up to roll up their sleeves, and we hope all of them will.
Thank you. We still have so many questions, but I'm conscious of our time. So I'm going to end with this one by Brian, who says, I love the power of kindness. Can you talk about how the lessons you learned in that book help inform how you've approached and handled the last 9 months?
Oh, thank you so much for that question, Brian. The thing about, actually is one of the things that I only kind of touched on in The Power of Kindness. And that is that, I said we're hardwired for kindness. That means it's our natural tendency to want to be kind to other people, without which we would not have built the civilization that we have. We would have been, we would have killed each other eons ago. We wouldn't take care of our children. We wouldn't take care of our communities. We wouldn't volunteer to help other people less fortunate. We wouldn't go to war to defend our country. So we have that hardwired into our brains. We also have this other hardwiring in a more primitive center in our brain, and that is, we have the ability to distinguish, almost instinctively, to distinguish between friend or foe. We will make a decision within nanoseconds of seeing a face, looking at facial expressions, listening to the tone of somebody's voice, listening to the words they use, the accent that they have. And within nanoseconds, we'll decide, this person could be my friend, or this person could be my enemy. Now you wonder, why do we have these dual natures in our brains? Well, I've already told you that we needed kindness to build civilization, but there was a time when we needed to protect ourselves against enemies. And there really were barbarians at the gate, and the people all over the next hill could kill us. Well, that is less likely to happen today, because we have society, we have laws. So why don't we kill each other? Why don't we just say, they're my enemy, that person's my enemy, that person's my enemy? Well, we have these giant frontal lobes, and we have executive function, and we say, oh, that's crazy. I don't believe that. And so we're able to suppress it. But, and this is a very important but, when we are under stress for whatever reason, I mean high stress. I don't mean, oh, I'm so stressed. I mean security. We're worried about our personal security. We think we're going to get killed. We think we're going to die of COVID. We think we're going to lose our job. We've lost our job. We don't know how to feed the family. We don't know how we're going to be able to stay in this home. We don't know how we're going to make next month's rent. There's another. Suddenly I'm getting all these phone calls. Under those circumstances of stress, our executive function is put on hold, and we're back to our basic instinct. And our basic instinct is one of kill or be killed, subdividing the world into us and them. So what I have learned in the last 8 or 9 months is to cut myself some slack, to do anything I can to relieve stress, to become an advocate for equalizing those income disparities that contribute to COVID-19, and to actually say and believe we are in this together. So for instance, this is my own personal political philosophy. I expect to be paying a COVID tax for the rest of my life. I will do it gladly to help my neighbor. And you know, I am blown away by the people out there who are extending kindness to others, who are looking in on seniors who are lonely and maybe are not able to get the food they need, or process a shopping order, and you know, maybe they're having a little bit of trouble with online grocery shopping, and they're helping them, and they're also addressing loneliness by providing company for them, and so we have this wellspring of kindness. And what we have to do is take steps to reduce our stress. Personally, I do things like I run, I meditate, and I try to remember the things that I have to be grateful for. And if you do the same things, I think it will work for you too. And I want to say it's been a pleasure to speak with you, and happy to answer your questions. And I really, really do believe that we are in this together.
Thank you so much for leaving us on a note of community and kindness, and for sharing all the insights that you have from your day-to-day. We can appreciate your time and what you're giving to this community so much, and especially with the simultaneous announcement today of Health Canada's approval of the vaccine, with a briefing going on this afternoon. So I know our viewers will keep following you for your insights. I'm sure you'll end up answering some of the questions a bit further in your podcast and on your shows. So thank you again. And to everyone watching, we will provide a recording and a follow-up email available for a limited time. And this is the last of our weekly series for the year. Thank you so much for your support. And we hope these sessions have helped provide inspiring and tactical content to help you both personally and professionally, as well as give you ideas on how we can help with great speakers, entertainers, and trainers for your event programming. We really want to help you kick off next year strong for your team, your members, and your clients. We will keep the chat open just for another minute or two for any last comments that you have. Dr. Goldman, we'll be sure to share these with you. Always a thrill to spend time with you. Really appreciate you sharing your knowledge. Awesome, amazing, thank you. Those are just a few. So to everyone watching, we hope you stay well and keep finding those silver linings. Thanks for joining us.